F5.
Where's F5?
It's not a procedure rank special.
No, there it is.
No? Oh, here it is. I see it. I see it. I can just find the arrow here. Oh, you disable the,
There you go.
no, you disable the touchpad.
There
Okay,
it
there
goes.
we go. Now now
Right there.
Ha! All right, very good. Slide doesn't look great, but anyway. So this is the patient who started it off for me. She was a 26-year-old woman from Casablanca, which you can't see there. I hope all the slides aren't like that, who was referred to me because of swelling in her neck. And she was actually referred for Sjogren's syndrome. And she had seen a number of doctors by the time she came to me. And so I asked what had been her first symptom 3 months earlier when she first became sick. And I'll never forget, she looked at me and her eyes got very big, and she said, "Thirst." I was thirsty. So Sjogren's syndrome seemed to make sense as a possible explanation for her problem. So over the next 45 minutes or so, I'm going to go from this picture of her neck that I took, to this. And I think it's really extraordinary that only in 7 years of first seeing this disease, we've been able to put together a very reasonable scheme of the pathophysiology of this condition. So we'll move fast and cover a lot of ground. These are my disclosures. So here is her neck. And I didn't know what she had. I thought maybe she had Sjogren's syndrome. And I began to read about swelling in the neck. These are her submandibular glands. And I knew that this was something interesting when I found this paper from 1979 in the Swedish medical literature. You can see this male patient here had a neck that looked just like the neck of my patient. And interestingly, the first author's last name was Sjogren, one of the many ironies. Not Henrik Sjogren, but Ingela Sjogren. And the title of this case report gave me the first hint that this might be a multi-organ disease that we were dealing with. Primary sclerosing cholangitis associated with fibrosis of the submandibular glands and pancreas. Remember that word, fibrosis, and some of the other organs as well. And I remembered from my days as a fellow reading about this entity described by Miklich, who was a Polish surgeon. And the pathologist at MGH in 1952 concluded that Miklich disease was nothing other than a variant of Sjogren's syndrome. And this gentleman, who was a 44-year-old man, you can see he has enormously swollen submandibular glands below his chin. His parotid glands are swollen as well, and his lacrimal glands were so swollen that he was unable to open his eyes. And when we began to become aware of IgG4-related disease, we realized there was a patient who looked just like this guy who had been followed in our clinic for 8 years. For Sjogren's syndrome had been his diagnosis. So we'll come back to this picture of the gentleman on the right when we get to treatment. So I didn't know what my patient had. I presented her at division conferences and was ultimately persuaded by my colleagues that one of these glands had to come out. If she had Sjogren's syndrome, she could have a lymphoma. So I sent her to ENT for a biopsy. They took the whole gland out. I was a little surprised by that, and that is 1 week after her surgery. And the pathologists were delayed in getting the report out. Finally, after 2 weeks, I went to pathology myself, and I sat down at the microscope with the guy and said, "Look, does the patient have lymphoma or not?" I saw all these mononuclear cells there, And he said, yeah, there are lymphocytes there, but look up here, just in the northwestern part of this slide. Wherever you look, there are plasma cells. This is a lymphoplasmacytic infiltrate. And then he made the very strange statement that it looks like she has autoimmune pancreatitis in her submandibular gland. So I have to confess, as a rheumatologist and as an alleged expert on autoimmunity, I didn't know anything about autoimmune pancreatitis 7 years ago. But it turns out that in 2001, the Japanese had described high levels of serum IgG4 in patients with what they called sclerosing pancreatitis. This was published in the New England Journal of Medicine in 2001. And the Japanese also coined a very nice metaphor for this disease. And the metaphor is, as the disease has been like a crow flying through the dark night of medical history. Because this disease has been there, it's been in our clinics, and by and large, we've all missed it or called it something else. But over the last 10 years or so, this crow has flown into light, and we now recognize that it is responsible for disease in essentially every organ system. The only organ systems that are not affected by this disease are the brain parenchyma, the meninges, yes, the pituitary gland, yes, but not the brain parenchyma, and skeletal muscle, and that's really about it. Everything else can be affected, and I will show you some examples of some, but not all of these. So this was her submandibular gland biopsy, another section. And a striking feature about this is that there are germinal centers throughout the submandibular gland. And when you think about it, it's highly unusual to have germinal centers in your submandibular gland. So let's take a minute and look at what goes on in germinal centers. So very early on in the lower right of the slide, you see an early interaction between a B cell and a helper T cell. And this disease really is about a dance between the B cell and the T cell at various stages. After this early interaction, the B cell migrates to the germinal center of the lymph node, where it proliferates and is educated by T cells, by T follicular helper cells, and by follicular dendritic cells. This immunology didn't exist when I was in medical school. I don't know about you, but it's all new, as far as I'm concerned, in the last decade or so. And the B cells undergo the process of somatic mutation and affinity maturation, learning to become the kinds of plasma cells, memory B cells, and plasmablasts that it will be after it emerges from the germinal center, called upon someday to make a very specific antibody. So that's a quick summary and perhaps a simplification of what goes on in a germinal center. But it's very relevant to the rest of the story. So before I cone down on the histopathology of the disease, I want to take a look at what the individual cells are that comprise this lesion. So there are B cells, and they're right where B cells are supposed to be. They're in the germinal centers, all the brown staining cells that you can see there. This is not a pre-malignant condition. The B cells are BCL2 negative. They are reactive germinal centers. They have follicular dendritic cells. They stain as they should in equal proportions for kappa and lambda. There are CD138 positive plasma cells, and the preponderance of these are IgG4 positive. But the most abundant cell in these lesions is a T cell. T cells have been known to be the most abundant cells in these lesions, and I will come back to that. So this is what the histopathology looks like. This is why my pathology colleague, whom I see almost every day now, said that it looked like my patient had autoimmune pancreatitis in her submandibular gland. This is autoimmune pancreatitis. Right in the center of the slide, you can see the pancreatic duct. Just like those germinal centers that had surrounded the submandibular gland ducts, this pancreatic duct is surrounded by a lymphoplasmacytic infiltrate, crowding out the duct. That's why my patient was thirsty. She couldn't make saliva. The other thing that you see is a swirling fibrosis throughout the tissue. This is what the pathologists call storiform fibrosis. I'm often asked why the pathologists call it storiform fibrosis, and I have to tell you, I don't know. I don't know where they got that name, but they call it storiform fibrosis. They don't know either. This is what autoimmune pancreatitis looks like radiologically. It is a large sausage-shaped pancreas. It's lost its normal pancreatic markings. And it's not the kind of pancreatitis that you see on the general medicine service with an incredibly tender belly, alcoholic pancreatitis. This is much more subtle. This slide shows meninges of 4 different patients from MGH who have hypertrophic pachymeningitis, IgG4-related pachymeningitis. This is what this meningitis looks like histopathologically. Again, you see a lymphoplasmacytic infiltrate enmeshed in this storiform fibrosis. And this is what the pancreas looks like histopathologically, lymphoplasmacytic infiltrate enmeshed in storiform fibrosis. One of my very astute fellows several years ago now said this disease is just like sarcoidosis. Wherever you biopsy, wherever you look, you see the same thing. You don't see non-caseating granulomata as you do in sarcoid, but you see lymphoplasmacytic infiltrate with a preponderance of IgG4 positive plasma cells, storiform fibrosis, and some other features that I will tell you about, regardless of the organ involved. Once we became aware of this disease, patients started coming out of the woodwork. So I was working with a fellow on this the first day of her fellowship in 2008. She heard me give medicine grand rounds about this disease. She was hooked, and for the next 4 years I worked with her on this. She was on the consult service and as a first-year fellow, and we were asked to see this patient who was a 68-year-old man who had just had his aorta replaced because he had an aortic dissection, which you can see there, and you can see the aortic dissection flap here. I heard about the case and I thought, well, this patient must have had occult giant cell arteritis and aortitis, and that's why he developed the dissection, and they just didn't find it until they replaced his aorta. But the vascular pathologist was more clever than I was, and he noticed the lymphoplasmacytic infiltrate in the aortic wall, which you see here, and he said, we should stain this for IgG4, and that's the IgG4 stain. All of the brown staining cells are IgG4 positive plasma cells. This was the first case of IgG4-related thoracic aortitis ever described. And once we knew the histopathological diagnosis, we checked the serum IgG4 and found that it was elevated to 10 times the upper limit of normal. Now let me say immediately that IgG4 itself is very unlikely to be the culprit, very unlikely to be pathogenic in this disease, because IgG4 is a peculiar antibody. It undergoes a process called FAB-ARM exchange in solution. So it is essentially a bispecific antibody. It doesn't have 2 identical FAB fragments, so it can't bind an antigen tightly. It also doesn't activate complement, at least not through the classical complement pathway. It binds to other immunoglobulins very weakly. And it's always been viewed as a downregulatory antibody. A little anecdote, beekeepers, very early in their careers have low serum IgG4 but after they've been stung a few thousand times, their serum IgG4 rises. This is thought to help prevent anaphylaxis. And the purpose of IgG4 may be, it's elevated in a lot of conditions, may be to serve as an antigen sink, to bind up antigen and downregulate ongoing inflammatory processes. So IgG4 is unlikely to be causing the problem, but it's a pretty good biomarker. So this is the pathology. Again, this is a submandibular gland. There's a lymphoplasmacytic infiltrate, which you can recognize by now. There's the storiform fibrosis, which you can see and recognize by now. But what you probably can't see is this right here. I would completely miss this. This was a vein, and it has undergone the process of obliterative phlebitis, which is another very typical histopathological hallmark of this disease. The disease is essentially a vasculitis in attacking veins like this, but work that we presented in London last week illustrated that about 25% of our patients have large vessel vasculitis as well. So here is a periaortitis, retroperitoneal fibrosis, another disease that you know and that you've seen through the years. In addition to the chronic periaortitis, the patient has a ureteral stent in because he had hydronephrosis. So what does this manifestation look like histopathologically? Well, here is an artery from the retroperitoneal biopsy, and I have outlined the vein for you. That was the vein. It's undergone obliterative phlebitis. That same lymphoplasmacytic infiltrate has moved right through the vessel and trashed it. And you really can't appreciate that unless you do an elastin stain. And with the elastin stain, you see a normal artery with an organized internal elastic lamina, but a completely disorganized vein because of obliterative phlebitis. This is what the disease looks like in the lung, gross pathology in the lung. It is a wedge resection of a lung. And the disease tends to track along the bronchovascular bundle, perhaps because of the location of the lymphatics. And everywhere you see an airway, here and here and here, you see disease. This is what the disease looks like grossly. These whitish globules are what the disease looks like in gross pathology in the lung, in the pancreas, in the submandibular gland, in the retroperitoneum. And this is what the lung looks like histopathologically. Here's the airway, and it looks rather like the pancreatic duct with a lymphoplasmacytic infiltrate surrounding it. Storiform fibrosis that you can see, the pinkish staining. And this is, I think, obliterative phlebitis in a vein running parallel with the airway. The disease is remarkably protean in the lung, probably more protean than in any other organ. Here you can see the thickening of the airways, tram tracking. My pulmonology colleagues tell me that this looks very much like sarcoidosis in the lung. Sometimes there can be pleural thickening, and we've recently identified a novel radiologic finding, and that is a paravertebral mass occurs in at least 10% of these patients. This is a CT scan of a kidney that is affected by tubulointerstitial nephritis. You can see the kidney is expanded. It has these hypodense lumps on its surface, and this is what IgG4-related tubulointerstitial nephritis looks like. And this is what it looks like histopathologically. Again, the same theme. We know we're in the kidney because here is a glomerulus. There's a lymphoplasmacytic infiltrate. There is storiform fibrosis throughout the tissue. You can also see a lot of eosinophils. And eosinophils are a minor histopathological criterion for the disease. And the eosinophils, which can also be present in the blood with a peripheral eosinophilia, raise the question of whether this is caused by Th2 inflammation. Here's a patient Dr. Merkel knows. I want to tell you about presentations of this disease with all of these different organ involvements. How does this disease present? One of the ways, the classic way, is as a mass lesion, a tumefactive lesion. That was his right eye. This is his left eye, and you can see something is badly wrong. And what is badly wrong is he's got an orbital pseudotumor mimicking, for all the world, granulomatosis with polyangiitis. He also has sinus disease, and he had renal dysfunction because of tubulointerstitial nephritis. But his biopsy showed IgG4-related disease. When I was in medical school, I remember the lecturer on the thyroid saying, we don't know what the hell Riedel's thyroiditis is. Well, Riedel's thyroiditis is IgG4-related disease of the thyroid gland. This patient had a hemithyroidectomy. You can see her original scar about 4 years earlier because of what they called Riedel's. And then it grew back, and she had to have the whole thing taken out. And we went back and reviewed the original histopathology and found the same histopathology that we find in the submandibular glands, in the pancreas, in the lungs, in the kidneys. So Riedel's thyroiditis is IgG4-related disease of the thyroid gland. Orbital pseudotumor with proptosis. You can see the proptosis here with the left eye jutting out. The lacrimal glands here and here are supposed to be tucked back in behind the orbital ridge, not so easy to see. But this CT scan tells us something else. I remember years back being at Hopkins, being referred patients by the ophthalmologists for orbital myositis. You can see that this patient's extraocular muscles are thickened. And we now know that this orbital myositis is a manifestation of IgG4-related disease. Second presentation, constitutional symptoms, weight loss, 15, 20, 25 pounds, occurring over months. This is not a stormy, hectic disease with fevers most of the time. It is very subacute. So weight loss, poor energy, lymphadenopathy, but the lymph nodes are usually diffuse, never more than 2 centimeters. Not hard, typically. Fevers are uncommon. The sedimentation rate is often very high because of the immune globulin, but the CRP is often not very high. Interesting dissociation there. And the patients look well. It really sneaks up on them. It's not like giant cell arteritis, not like granulomatosis with polyangiitis. It's very subtle and can go on for months before it's detected. The third common presentation is atopy. So the types of atopy that patients have, asthma, allergic rhinitis, nasal polyps, just very common manifestations of atopy, very elevated IgE. Again, all raising the question, is this all caused by Th2 pathway inflammation? Is it a Th2-driven disease? Much of the literature suggests that it is. So we looked at that recently in about 60 patients we had treated and put into remission. We followed them serially and looked for predictors of disease flares. And so 55% of the patients at baseline before they got any kind of treatment had an elevated serum IgG4. Not 100%, far lower, actually. So serum IgG4 is not a great diagnostic biomarker, but it is a very good predictor, if it is elevated, that that patient is going to flare again. So divided into quartiles, patients in the highest quartile of IgG4 began to flare much earlier than those who were in the lowest quartile. And this was associated with a very high hazard ratio for disease flare. The same is true for IgE. We could almost call this disease IgE-related disease rather than IgG4-related disease. 45% had an elevated IgE and sometimes remarkably high before treatment. And an elevated IgE at baseline also predicts disease flare, ultimately, even if following successful remission. And the third major predictor of disease flare was eosinophils, a peripheral eosinophilia. Those in the highest quartile flared much more quickly than those with no baseline eosinophilia. All of this suggests maybe a Th2 pathway is the key, and much of the literature to date has really suggested that that is the case. But our group actually looked at this carefully. We had a visiting allergist from Italy, Emanuele Della Torre, and he took a very careful look at our patients and atopy and IgE and eosinophilia. And we published this paper last year describing that patients with IgG4-related disease, if they have a history of atopy well before their IgG4-related disease is diagnosed, if they had atopy at baseline, then they are much more likely to have elevated Th2 inflammation, GATA3 cells in their blood. Those who were non-atopic were no more likely than were healthy control patients, seeming to debunk the notion that Th2 inflammation is the driver of this. And we have some more things that I'll come to at the end, which ties this together in a new way. But let's turn now to treatment. What does treatment tell us about the disease? We have learned an awful lot about this disease by being able to give targeted therapy to treat these patients. So for treatment, I want to turn back to this story and compare the patient from 1892 described by Miklich to the patient who'd been followed in our clinic for 8 years for the diagnosis of Sjogren's syndrome. So our patient was a 55-year-old man whose history, when one sort of thinks back on it, was very atypical for Sjogren's syndrome. He had asthma. He had had left eye swelling, not a typical feature of Sjogren's syndrome. He had had enlargement of his extraocular muscles, also not typical of Sjogren's syndrome. No one knew what he had, and he had been treated with steroids, which really hadn't helped very much, or at least stopped helping. Then he developed parotid enlargement, and this is when Sjogren's syndrome began to be considered the diagnosis. And he had lymphadenopathy. And he had these things biopsied, and the pathologist just said, reactive inflammation. That's all. Steroids weren't working anymore. He was put on methotrexate. So this is what his parotid glands look like, and I've certainly seen a lot of patients with Sjogren's who had parotid glands that looked just like that, and I think a lot of them did have Sjogren's syndrome. But his serum IgG4 was greater than 1,500, and we were at a loss as to what to do for this guy who had been refractory to steroids and methotrexate. And so we treated him with B-cell depletion. And this was one of the eureka moments. 2 months later, without any other intervention, his parotid glands looked like that on the right, and his serum IgG4 had fallen dramatically from baseline. And very recently, just a couple of months ago, we published a 30-patient trial describing the apparent efficacy of B-cell depletion in this disease. Dr. 414 has been perhaps our most informative patient to date. He is a physician, and before coming to see us, he had been told over a 3-year period that he had multiple myeloma, lymphoma, and pancreatic cancer, all of which fortunately turned out not to be true. You can see he has such swelling of his sublingual glands that they've herniated down through the floor of his mouth. He has lacrimal gland enlargement. And these were his baseline labs when we saw him on no treatment. C-reactive protein is a little bit elevated, but he was really slowly dying. His albumin was 2.7, and his globulin fraction R. And all patients with IgG4-related disease have a similar oligoclonal increase, usually with a dominant clone in a T cell. And this T cell is unusual. It hasn't been described in humans before. It makes unusual cytokines. It makes interferon gamma. It makes TGF-beta, IL-1, unusual cytokines for T cells to make. It makes other unusual products for CD4 positive cells. It makes perforin and granzyme B, things that we associate more with killer cells. And it has surface markers that have previously not been described on T cells. So we also perform next-generation sequencing after separating patients according to Th2 cells and this CD4 cytotoxic lymphocyte. And what we find is in the Th2 cells, their next-generation sequencing just suggests that their Th2 cells have proliferated in response to every allergen they ever saw their entire life. And in contrast, this CD4 positive cytotoxic T lymphocytes, this new cell, is expanded in an oligoclonal fashion, suggesting that it is responding to antigen presentation. This is an in situ hybridization stain for this T cell, and one of its cell surface markers. All of the little pink stains are the RNA of this cell. So in addition, or the RNA for that marker. So in addition to being in the blood, expanded in a dramatic oligoclonal fashion, the cell is found throughout the lesions of patients with this disease. This is Dr. 414's submandibular gland biopsy. So this brings me back to the second slide and a scheme of the pathophysiology that we've been able to put together in a rather short time, just from observations of individual patients and careful study of them in the lab. And we think that the disease is all about this B cell, T cell dance, with plasmablasts and perhaps B cells too, presenting antigen to this CD4 positive killer cell. And the CD4 killer cell makes interferon gamma and TGF-beta and perforin and granzyme B and granulysin, leading to tissue injury and to fibrosis. And we think that the products of this cell drive the fibrosis, the storiform fibrosis that's so characteristic of this disease. Where does IgG4 fit into this? It is very much off in the periphery in our way of thinking. It is being produced as a down-regulatory response, trying ineffectually to restrain this ongoing tissue inflammation, which is due to another primary response. So that was almost my last slide. These are our current directions. We're working on a new treatment for the B cell line, which will target CD19 cells. There is the possibility of inhibiting directly this CD4 killer cell. And we're very interested in trying to determine what the initial trigger is for these patients. We suspect that the trigger is different for every patient, but there may be a small group of antigens that tend to trigger this disease in different patients. So, in conclusion, IgG4-related disease is a great mimicker. Oeser called syphilis the great mimicker. This disease is really a great mimicker of our era. pathology is the key to diagnosis. I don't know of another disease where clinico-pathologic correlation is more important. So important to sit down at the microscope with the pathologist and go over the case. Plasmablasts are a useful biomarker, and the first rheumatic disease, I think, to have a cell as a biomarker. B-cell depletion is effective, perhaps through its effects on a novel T-cell population. And we believe that what we've learned from this disease is probably highly relevant to lots of other immune-mediated conditions. So, those of you who know me know I didn't do all this work myself. I'm a clinician, but I have wonderful laboratory collaborators, Dr. Shiv Pillai at MGH, his incredibly talented postdocs, Hamid Matu and Vinay Mahajan, my pathology colleague, Vikram Deshpande, one of a superb series of rheumatology fellows, Zach Wallace, whom I've worked with, and Masha Kulikova, who's a research coordinator. So thank you very much. I'd be delighted to try to answer any questions. Yes, Gary.
I was wondering if you were suspicious of IG4, have you had occasion where if there wasn't a swollen neck or anything to pinpoint where you would do a blind biopsy?
There is almost always an organ that is abnormal in this disease. I recently saw a 32-year-old physician, just finished his residency, who has had a 15-pound weight loss going back months, decreased energy, and he has lymphadenopathy. And these have been biopsied, and his lymph nodes are 95%, the plasma cells are 95% IgG4. There's always an organ. If the serum IgG4 is elevated but there's no obvious organ dysfunction, it's probably not IgG4-related disease because there are a whole bunch of other things that can cause elevated serum IgG4-related disease. In the one case where I really thought it seemed like it had to be because the IgG4 was so high, there was no organ involvement. There was no organ dysfunction. And my ultimate conclusion was that this patient had come from India and he had just been exposed to so many different allergens, and that's why his IgG4 was elevated. So there's always organ dysfunction. Yes?
Conventional wisdom is that we have the APC that stimulates the T cell and then that stimulates the B cell. This is almost backwards. Do you know another condition where the B cell drives the T cell response?
Well, I think, we've learned a lot about what B cells do. When I was in medical school, we thought B cells became plasma cells, which made antibodies, and that was it. But we now know that they present antigen. They're well known to do that. And I think plasmablasts are also known to present antigen, and they make cytokines and do a lot of other things. So I don't think that this is really unusual from that perspective. What is unusual is the T cell. Yes?
Dr. 414.
Yeah.
You showed that the immunoglobulin went up, plasma stayed down, but was that immunoglobulin IgG4? Yes,
The great majority of his IgG was IgG4. He had his IgG4 was 5,000 milligrams per deciliter, just off the charts, 50 times the upper limit of normal. He still holds the hospital record for serum IgG4. Yes, Charlie.
We know that some T cells do carry the CD20 antigen. Did you stain any of the T cells for that? Think about that.
That's a good question. It has been. The short answer is no. We haven't done that, but I am aware of that theory, and I guess it's been demonstrated that some T cells do have CD20. I don't know how carefully we've looked at that, but it's obviously a good question. Peter.
Perfect as always. We're looking for this, we find it. When should we say it's not? So, we talked about certain ratio of IgG4 to et cetera. But as we do more stains, we're invariably going to develop possible diagnostic risk
Yeah, it's a clinical pathologic diagnosis. Pathology is the key. Elevated serum IgG4 can be suggestive, but does not confirm the diagnosis. Finding IgG4 positive plasma cells in tissue does not confirm the diagnosis. It's much more about the histopathology and this storiform fibrosis, obliterative phlebitis. And so you have to have compatible histopathology and a compatible clinical story, with some of these organ manifestations that I've told you about. And you're right. I mean, there are a lot of things are being labeled IgG4 related disease that I think that are not. Yes, Alan.
There are certainly times where biopsies are difficult for one reason or another.
Yeah.
And you showed us that only perhaps 55% of the time is IgG4 plasma elevated.
Right.
So could you rely upon assays with plasma blasts to help support a diagnosis, or any other findings that you might suggest?
The key word is support, because an elevated plasma blast concentration is also not diagnostic of IgG4 related disease. But if it's a classic organ manifestation, if the patient has, peri-aortitis and an elevated serum IgG4 plus minus and an elevated plasma blast concentration, which you can't get commercially so easily, we do it in our research lab, but if I see that, it's not so easy to biopsy the aorta, and I might be satisfied that the better part of valor is simply to treat the patient, rather than doing a heroic biopsy. Yes?
Have you noticed any differences between the patients who have a normal serum IgG4 compared to the ones that have elevated serum IgG4?
Yeah, the main difference, I think, is that those with elevated serum IgG4 are going to need more treatment. They both respond to therapy, probably equally well, but those with an elevated serum IgG4 are not going to be fixed for any long duration. They're going to have to be treated again much more quickly. They flare faster. They also tend to have, if elevated serum IgG4, they tend to have more organs involved. And it stands to reason, I think they've just got more sites of disease. Those are the primary differences. Yes? Oh, no, I don't think so. It can cause organ failure, it can cause death, but there are also cases of spontaneous improvement described, at least temporary. And a word that I learned in the context of this disease is metachronous. So it doesn't always present synchronously with all of the organs at once. It presents metachronously. So one time it might be the submandibular gland swollen, and then 10 years later the patient presents with renal disease. And they sort of remember that, yeah, I had swelling of my submandibular glands, and they thought I might have Sjogren's. So it does it can wax and wane, but I don't think it ever goes away completely most of the time, but it can wax and wane and have temporary organ improvement. Yes?
John, has anybody made any attempt to quantitate the amount of inflammatory versus fibrotic tissue in these lesions? And could that have any influence on the response to therapy and long-term prognosis?
No, that's a great question. And I think the answer is yes. The more fibrotic a tissue is, the less likely it is to respond to our typical immunosuppressive agents. We have shown that B-cell depletion actually decreases the activation of smooth muscle actin, but it doesn't have lead to a huge clinical improvement in fibrosis. So I think the more fibrotic an organ is, the less likely it is to respond to therapy. Yes?
One of the parts of the syndrome is retroperitoneal fibrosis.
Yep.
Like many of the others, it's an entity that's been known for 15 lives. As you look back into the pathology specimens from some of those patients, was it distinguishable at that time from fibrosis, whether there was like lesions? I also recall there were
methosurgide, for example. Yeah.
Are there any instances where any medications are?
You know, I actually have pulled those papers from the 1930s, JAMA, describing the association of methosurgide and retroperitoneal fibrosis. And in those days, they gave methosurgide for almost everything. And so I suspect that the association is true, and unrelated, that the methosurgide did not have anything to do with it, and the patients just developed retroperitoneal fibrosis. Mm-hmm.
And from my recollection, most of the time you treat these children with corticosteroids. Remember the ones who also had a methotrexate regimen, and they all seem to get better.
Mm-hmm.
Now, of course, I don't have long-term follow-up, but I would wonder if some of those might be.
That's a great question. I mean, I've got to think if a kid's got a swollen eye, he's going to be taken to a doctor. Maybe they're going to be reluctant to biopsy it, and the kid might just be put on steroids. Certainly that has been the approach of ophthalmologists for years, and they have not gotten tissue because of concern of doing damage. And I think that's misguided. Orbital masses are complicated. It's not all GPA. It's not all IgG4-related disease. It can be Erdheim-Chester disease. It can be a bunch of other things, including lymphoma. So they really should be biopsied. And part of the reason it took us so long to identify this disease is because people didn't do biopsies. And when they did, pathologists didn't parse it carefully enough. Maybe final question?
Do you think that abatacept might be able to be used as an alternative agent for rituximab?
Yes, I do. I think it's a very appealing thought that a T-cell directed therapy might be useful here. I haven't tried it, but I think it's a very good thought. Oh, Tony, one more.
It's interesting that a subset of patients have low complement,
Yeah.
suggesting maybe an immunocomplex driven disease. My understanding is that IgG4 does not fix complement.
Right.
How do you explain this low complement?
So we don't know completely, but there are a couple of possible explanations. One is that the immune complexes are actually formed by IgG1 and IgG3, which do bind complement well. And we see patients where all four immunoglobulin subclasses are elevated. So it could be the other immunoglobulins that are doing it. And the other is that IgG4 can apparently activate complement through the mannose binding pathway. And so that's another possibility. Complement biology is complicated. I've never fully understood it, but there is apparently a way that they could, in theory, IgG4 could activate the system. Well, thank you very much.